Hello, everyone, and welcome to the Oregon Rural Health Conference, brought to you by the Oregon Office of Rural Health. My name is Robert Dimmick, and I'm the Interim Director of the Oregon Office of Rural Health, and we're really excited to have you here with us this morning. November 11th, Veterans Day, and we are very excited to bring you a session focused on healthcare directed at our veterans here in rural Oregon. First, I'd like to thank our partners. We have gold partners, All Care Health and the Oregon Rural Health Association. We have silver partners, Eastern Oregon Coordinated Care Organization, the Oregon Association of Hospitals and Health Systems, and River House on the Deschutes. And our bronze partner, RQI Partners, and our copper partners, Westcom and American College of Education and Inquisync. Without their support, we wouldn't be able to bring this conference to you this year at no charge. So we really appreciate their support. You should have received an email from us with a link to our conference app. You can use that app to visit our partners' virtual booths. You can find out about our partners. You can enter to win prizes, network with your colleagues and new friends, and to share pictures of your local community. See, also, along with the evaluation, you will get a chance to win a $100 gift card. So please help us know how we're doing, and help us improve. With that, I'd like to turn it over to our presenters. Mary Patzel is the Program Manager and Quality Analyst with ORPRN, the Oregon Rural Practice Research Network. And Lacey Carter is Aging Veteran Outreach Specialist with the Oregon Department of Veterans Affairs. And it's all yours.
Perfect, thank you, and thanks for having me today. My name is Mary Patzel. I'm a project manager and qualitative analyst at the Oregon Rural Practice-Based Research Network, or ORPRN for short. We're a research department at OHSU that works with primary care practices across Oregon to conduct implementation science. Today, I'll be talking about challenges and opportunities in providing care for rural veterans, specifically from interviews with non-VA affiliated primary care clinicians and staff members. So to start off, I'm going to give you a little bit of background about the research and about findings. Our research is funded by a grant through the VA Office of Rural Health. The Office of Rural Health has a network of satellite offices called Veterans Rural Health Resource Centers, or VRHRCs. These are different hubs to serve and coordinate rural healthcare research, innovation, and dissemination. These different hubs are across the United States, and the Portland, Oregon location is the most recently established. It came into being in 2019. While they all promote rural research, they tend to have a slightly different focus, and the Portland location focuses on increasing access to care, preventing rural veteran suicide, and innovating to combat the pain and opioid epidemic. On this next slide, you will see the different locations of the 5 VRHRCs across the United States. So there's one in Gainesville, Florida, one in White River Junction, Vermont, a location in Iowa City, Salt Lake City, and then the Portland one. Next slide. These are examples of some of the 2020 research projects that came out of the Portland Hub, which range from looking at firearm injuries to the impacts of community gardens. This also includes our research, which I'll talk more about today, looking at rural veterans and their access to primary care. Specifically, we looked at how recent legislation called the Mission Act impacted access to and experience of care for rural veterans. Next slide. So why focus on rural veterans? Well, 1 in 4 veterans lives in the rural area of the United States, and that's close to 5 million total. And not only that, but VA facilities tend to cluster in urban areas with higher populations. So it can be difficult for veterans in rural areas to access VA doctors. A little bit of a primer on VA healthcare for those who may not be as familiar. The VA provides healthcare to almost 9 million veterans. Largely, the VA serves veterans who are getting care for health issues tied to their time in the military, or for veterans who meet specific income requirements. So the VA tends to serve older, poorer, and sicker veterans than those who might be accessing healthcare through other financial or insurance avenues. For those veterans who may need care beyond what the VA can provide, whether due to long travel distance or wait times or specialist availability, the VA has implemented different iterations of what they call community care. And community care is an overarching term to describe when veterans receive care from non-VA clinics, but the cost of their care is still covered by the VA. The Mission Act is the most recent legislative iteration of the community care program, and it was enacted in summer 2019 and replaced a predecessor program called the Veterans Choice Program. The most notable change from the Choice Program to the Mission Act includes this geographic distance requirement. So veterans used to be eligible for community care if they resided outside a 40-mile radius from the VA. And with the Mission Act, that changed that they were eligible for community care if they resided outside a 30-minute drive time radius from a VA facility. And this can actually make a pretty big difference in rural areas where there are fewer direct roads, but also in urban areas where traffic can be a big impediment. Ready for the next slide. So over the course of 2020, we conducted research to better understand rural veteran access to and experience of primary care. In particular, we wondered how and if the passage of the Mission Act changed access to care in rural areas. We conducted semi-structured interviews with veterans, VA-affiliated staff and clinicians, veteran service officers, and non-VA providers and clinic staff. We conducted these interviews between May and August 2020, and then analyzed the findings for themes. So today I'm going to focus on the results from our interviews with non-VA clinicians and staff because I thought that would be the most relevant to our audience and to the work that you all do. So this slide breaks down the demographics of the 13 informants we spoke with. Important takeaways include their varied roles as clinic staff, physicians, nurse practitioners, and physician's assistants. Also note that 16% were both clinic staff, but also had served and were veterans. On the next slide, you'll see a map showing the geographic spread of our participants across Washington, Idaho, and Oregon. Next slide, please. So after conducting interviews and coding for themes, we found that most fell into 4 main categories. Those categories were barriers to providing care to veterans, factors that influence whether veterans choose to be seen by a VA or a non-VA provider, perceptions and viewpoints of the Mission Act, and suggestions for improvement in the future. I'll start with talking about barriers to providing care for rural veterans. And this is a bit of a hefty slide, so we'll stay here for a minute. These barriers largely fall into 2 main categories relating to process challenges and variation and inconsistency. In regards to process challenges, we found that staff members noted a lot of difficulty surrounding the bureaucracy of the VA. One major hurdle was the unclear and difficult process for record sharing. Informants noted that electronic record sharing was nearly unheard of, and those that did receive records back would often get these really big stacks of documents they had to sift through manually, making it burdensome to really use any of the records that were coming from the VA. As you can imagine, this often led informants to feel like care was fragmented between the VA and outside providers. While this was particularly apparent with records, the burden of VA processes was also seen with other types of paperwork, such as referral requests, payments, and authorizations. Paperwork submitted to the VA was often really delayed or just completely lost. And informants mentioned needing to resubmit multiple times for things like prescriptions and specialist referrals. There's a heavy reliance on complicated phone trees and faxing or mailing documents in the VA instead of more current information exchanges. Overall, a lot of our informants noted that it's just hard to know who to contact at the VA and how to get answers. So the bottom 3 barriers highlight more of the inconsistency and variation involved in dealing with the VA. Community care consultations were a major pain point. And to give a little bit of background, in order to be authorized to use the Mission Act to get care from non-VA providers and have it be covered by VA benefits, veterans need a special authorization. This authorization process changed from the prior Choice Act to the Mission Act, and now veterans were required to have a VA doctor see them to authorize their community care, and this had to be repeated every 6 or 12 months, depending on the situation. This made for a lot of confusion and delays. In addition, some informants noted that under prior legislation, they could do a lot of the authorization paperwork on behalf of their veteran patients, but now it had to be handled directly by the veteran, causing a lot of issues. Informants noted differences in the coverage provided by VA benefits. One example of this was a patient who was forced to use tanks of oxygen because his VA benefits wouldn't cover a portable oxygen concentrator. This barrier brought up a lot of conversation around dual coverage and veterans and how they often use multiple types of insurance and carefully planned how to bill their health. I'm going to start that sentence over. Informants also noted differences in the coverage provided by VA benefits. One example of this was a patient who was forced to use tanks of oxygen because his VA benefits wouldn't cover a portable oxygen concentrator. This barrier brought up a lot of conversation around dual coverage of veterans and how they often had multiple types of insurance and carefully planned how to bill their care depending on the procedure or need. Worse yet, some said that veterans, rather than strategically working within their coverage, would just respond to limitations in coverage by refusing needed care. Nearly all community clinic informants we spoke with expressed some degree of confusion or uncertainty about VA procedures and policies. Several said that they had received contradictory information about proper routes or channels for interacting with the VA, or got different answers depending on who they spoke with. This next slide will highlight a few quotes from participants that help illustrate some of the barriers they were facing in caring for veterans. This first quote is from one of our clinic informants, and they were discussing the frustration with the lack of electronic health records compatibility. They said, quote, "In an era when health is so data-driven and is only going to become more so, having these siloed EHRs, it just doesn't work. It's not going to be practical in the long run." And this was a sentiment we heard a lot. Healthcare is changing and the method of delivery is changing, and the VA interface just wasn't keeping up. This second quote was from another clinic staff member who was also a veteran. And they spoke a little bit about how the VA got to be so bureaucratically difficult to work with. They noted that, quote, "All of the VA people I've spoken with really truly love their veterans and they have buy-in and they're doing their best. I think the system is just very, very poorly built and things do not flow the way that they should. And there's no rhyme or reason other than it has been cobbled together over all these processes for so many years. And nothing was ever streamlined. It was just adapted, adapted, adapted." Next, I'll dive into some of the factors we found to commonly influence whether a veteran sought care through the VA, through non-VA providers, or through a blend of both. Largely, we found that distance and location to VA care was a major factor in decision-making. Many informants stated that veterans saw community providers because they were available nearby, and the closest VA may be hours worth of a drive. Age of patient also played into this subset, with older veterans having more difficulty securing transportation, whereas younger veterans could often drive themselves and were willing to longer distances. We found that availability of appointments was another big consideration. Informants described how veterans often wait significantly longer to secure appointments at VA clinics than non-VA clinics. But this was not necessarily true for all types of care. Mental health services and nursing home facilities were both noted as having more readily available care through the VA than through private facilities in the areas that we sampled. Care considerations definitely played into veteran choice of care. Some services were covered more fully by the VA than is typical with other insurances, and VA coverage was even described as generous. However, Several providers reported that patients often face a choice between using secondary insurance and paying a copay, or dealing with the hassle of their VA benefits to get something covered at 100%. Several community informants said that their patients experience more hassles receiving care from the VA, and this quote at the bottom of the slide is a great example of that. The participant noted that recently a lot of veterans have not been happy with the VA, and a lot of them look to start going through their own insurance just because they're not happy with how long it takes and the rigmarole they have to go through to get their stuff paid for. To me, this really illustrates both the cost and the convenience factor, because veterans can get their care paid for, but it might be so burdensome it feels impossible, or at least beyond reasonable standards. Finally, the perception of quality of care was often discussed. Several interviewees mentioned that their patients can feel like a number when receiving care at the VA due to frequent staff turnover. Errors also fell into this category of quality of care. Some informants have specific stories. One story involved a patient who had stopped going to the VA after a doctor had told him to get his affairs in order because he didn't have long to live. It turns out this doctor was looking at the wrong record and speaking with the wrong patient. But a lot of community clinic informants did mention that veterans receive a fair amount of care through the VA. It's not all doom and gloom. One major benefit noted about the VA was the idea of community and veteran identity. The VA was noted as a place where there's a lot of pride and culture, and where folks go to swap war stories or talk about identity as a prior service member. Depending on if a veteran wants to talk about their identity as a veteran or would prefer to be treated without an emphasis on that background, may impact where they choose to receive care. So, what did our informants ultimately think about the Mission Act? Well, for the most part, they weren't very familiar with it. The title may or may not have rang a bell. Many informants tended to conflate or confuse it with earlier community care programs. This is perhaps due to the fact that the Mission Act had a relatively small impact on the rural primary care clinics we spoke with. Many noted that the Mission Act didn't really change the number of veterans they saw. Many were already outside that 40-mile radius from a VA facility, and so changing it to a 30-minute drive time didn't change a lot of the number of veterans. Overall, it seemed that non-clinician staff had a slightly more nuanced understanding of the distinct changes under the Mission Act, likely due to their dealings with billing and regulation changes. We found a slight preference for the previous system with our informants, largely, as I mentioned, because they felt that the authorization process was easier under the old program, and veterans didn't have to go to the VA provider for the authorizations as frequently. There was also a lot of changes with billing and on-time payments that informants noted, stating for many this may jeopardize their ability to continue seeing patients in the future. Finally, I'd like to speak a little bit about suggestions we heard for improvement. It probably won't come as a surprise that simpler processes and easier interactions with the VA was a major priority. Many informants wanted to understand how to provide rural care to veterans and work with their VA counterparts, but didn't know where or how to get this information. Better outreach, trainings, and educational materials were suggested. Another note was that care authorizations for community primary care without 6 or 12-month time limits would be much easier and reduce administrative burden, non-payments, and veteran cancellation of appointments. Next slide, please. So, how do these findings from non-VA clinicians and staff members align or diverge from other informant groups we sampled? Well, in comparing perspectives of VA-affiliated informants, veteran service organizations, and non-VA affiliated informants, we noticed that all mentioned a difficulty in record sharing. The perception of the VA processes as outdated or complicated was common amongst all. A hot topic was the difficulty of retention of medical staff in rural areas for both VA facilities and non-VA facilities. And there was also agreement that in order to successfully navigate the VA, most individuals relied on personal connections. So having that go-to person that they could call up and get an answer from. We did find some differences in ideas between our informant groups. We found that a lot of varied familiarity with the Mission Act. As I noted earlier, non-VA staff had a limited understanding of the specifics of the Mission Act, while their VA counterparts and veteran service officers were very well versed in the details and the nuance of the new program. We also found an interesting difference in perceptions of why veterans seek care at different locations. VA and VSO informants often noted that the VA created relationships with patients more successfully because of this common military background, while community providers had many stories of veterans feeling like a number at the VA and seeking care outside of the system. So while all informants noted the importance of relationship, they tended to disagree on where this was most successfully built for veterans. So those are the main findings of our preliminary research. Many of the barriers to providing care for rural veterans identified by our informants, such as complicated processes, delayed and lost paperwork, limitations in the VA, are systemic issues and are presumably faced by urban areas as well. But because veterans in rural areas are more likely to get their care from community providers, these issues probably disproportionately affect them. Our findings bring up an interesting conflict in the goals of the Mission Act. While one goal of the Mission Act is to improve access to health care for veterans by making it easier for them to access care from community providers, and as a health plan, the VA is ensuring that veterans receive the care they are entitled to through this law, there's this flip side where, as an organization dependent on veterans obtaining care from its own providers, the VA is incentivized to encourage veterans to stay within the VA for care. So you get this interesting push and pull of the VA trying to increase access to care, but also being incentivized to bring veterans inside for care to buffer against efforts to privatize VA healthcare. In order to continue advancing our research, our team is working to continue supplemental data collection. We also plan to further explore the impact of COVID-19 on rural veterans and their care providers. Finally, in 2021, we are looking forward to utilizing these findings to identify and prioritize some future interventions. Thank you for taking time to listen to my talk today. I want to make sure that I thank my team and I thank the participants who engaged in our research. I also want to make sure to thank the VRHRC who funded this research this year. Next slide. I'd be happy to take any questions either via email, in the chat, or during our Q&A session after Lacey's talk. I'll pass it over to Lacey Carter now. She's got a great presentation and will cover some additional resources.
Thank you so much, Mary. I really appreciate it. And thank you for having me today. I'm excited to have an opportunity to talk about engaging with veterans, specifically rural veterans. So let's just jump right in. Many veterans choose to live in rural and remote areas for the lower cost of living, greater privacy, less crowding, and more space for recreation. According to the VA Office of Rural Health, 4.7 million veterans live in rural communities across the United States, and more than 2.8 million rural veterans rely on VA for their health care, a significantly higher percentage than the 37% enrollment rate of urban veterans. Veterans are more likely to live in rural areas than Americans who did not serve in the military. While 19% of Americans live in rural areas, almost a quarter of veterans do. Compared to urban areas, rural communities tend to have higher poverty rates, more elderly residents, and residents with poorer health. These same trends are seen in the rural veteran populations in comparison to their urban counterparts. 57% of rural veterans are enrolled in the VA healthcare system, like we mentioned, significantly higher than the 37% enrollment rate of urban veterans. 55% of rural enrolled veterans have at least one service-connected condition or disability. 7% of enrolled rural veterans are women. 25% of enrolled rural veterans are minorities. 55% earn less than $35,000 annually, and 35% do not access the internet at home. Rural veterans enrolled in VA's healthcare system are also significantly older. 55% are over the age of 65. This older veteran population is medically complex and more likely to be diagnosed with diabetes, obesity, high blood pressure, and heart conditions that require more frequent, ongoing, and costly care. The next generation of rural veterans also has multiple medical and combat-related issues, which will require significant ongoing access to care. Nearly 460,000 of the rural veterans served in Iraq and Afghanistan. Thank you. While veterans may enjoy the benefits of rural living, they may also experience rural health care challenges that are intensified by combat-related injuries and illnesses. Just like any rural resident, it may be difficult for rural veterans and their caregivers to access healthcare and other services due to rural delivery challenges that include fewer hospitals, providers and clinics, fewer housing, education, employment, and transportation options, greater geographic and distance barriers, limited broadband internet, higher uninsured rates, difficulty of safely aging in place, and the stigma and lack of anonymity in accessing services. The bottom line is that rural health providers are likely to encounter veterans, and that veterans have healthcare needs and issues that are unique. According to the Oregon Veterans Behavioral Health Study that was conducted in partnership by the Oregon Department of Veterans Affairs and Oregon Health Authority in 2018, about 2 out of 3 Oregon veterans receive physical and behavioral health care through the private sector. 9% of Oregon veterans are on the Oregon Health Plan. A clinician may be able to determine if their patient is a military veteran if it has been documented in the record. They may also consider adding questions about military service to clinic and service intake forms. If there's not information in the record, the first thing a provider can do is listen and look for clues that their patient may be a veteran. He or she may address the provider as sir or ma'am, even though they may be younger than the provider. The presence of tattoos, different apparel, accessories, memorabilia may all be clues that the patient has prior military experience. This can be a great way to initiate the conversation about being a veteran. The first step in assessing if a patient is a veteran is simply to ask, have you had any experience in the military or did you serve in the military? The assessment of veteran status is a safety issue in which there are real health risks for veterans that, if not properly included within the treatment plan, may result in serious short and long-term health consequences for veterans and their families. Once it's been established that they're a veteran, you can follow up by asking if they know if their military experience has had any long-term impact on their health. Engaging veterans about their military experiences may be helpful in assessing and developing a plan of care. The U.S. Department of Veterans Affairs has compiled and posted on their website a military history pocket card for clinicians, which has assessment questions they recommend for trainees and clinicians to enhance veteran-centered care. Strategies for working with veterans include learning about their military service, acknowledging their military experience, evaluation of their functional status, increasing the health literacy of veterans and their families, complementing VA care services, and encouraging connection to VA and/or veteran service organizations. One amazing free resource is the Psych Armor Institute. Healthcare providers already understand the value of cultural awareness in their practices, and Psych Armor can enhance that even more. They have provider courses like 15 Things Veterans Want Healthcare Providers to Know, Connecting with the VA, Veteran 101, Military Culture, and a whole lot of other additional courses that provide clinicians with education, tools, and resources to better care for veterans and their families. Healthcare providers around the country have been taking Psych Armor's courses on military culture and veteran-specific topics to enhance their care to military veterans and their families. In recognition of those efforts, Psych Armor offers a Veteran-Ready Healthcare Provider Certificate. This certificate allows providers to showcase their commitment to better care for veterans and their families. Veterans may have been exposed to a range of chemical, physical, and environmental hazards during military service. Chemicals, radiation, air pollutants, occupational hazards, and warfare agents are some examples of hazards veterans may have been exposed to. Agent Orange, for instance, is a chemical exposure that can cause type 2 diabetes, ischemic heart disease, certain cancers. Radiation exposure can cause certain cancers, leukemia, multiple myelomas. Air pollutants like burn pit smoke, dust can cause skin conditions and chronic fatigue syndrome. Warfare agents, chemical and biological weapons can be the cause of a variety of different cancers and skin conditions. Military service impacts veterans' health for the course of their lifetime. Not only have they had unique exposures during service, but they face other healthcare challenges and conditions over the course of their lives that differ from their civilian counterparts. For instance, ALS is now a presumptively compensable illness through the VA for all veterans with 90 days or more of continuously active service in the military, based on a November 2006 report by the National Academy of Sciences Institute on the association between active duty services and ALS. The Secretary of Veterans Affairs, Dr. James Peake, said that veterans are developing ALS in rates higher than the general population. So once a provider has established that their patient is a veteran, it is especially important to pay particular attention to signs of specific challenges or health issues. Providers can explore actions that the patient has or has not taken to resolve any potential military-related health concerns and determine if further assistance may be required beyond the scope of their practice, such as a referral to the Department of Veterans Affairs or other community resources. So it's important, obviously, to discuss those referral options with the veteran so that they are taking part in decisions related to their healthcare needs. There are a multitude of federal, state, and local government agencies, national service organizations, and community partners who provide services and resources to veterans and their families, both urban and rural. There really is not a single entity who is able to meet all of the needs of all rural veterans, so collaboration and partnership is essential. The Oregon Department of Veterans Affairs provides a great deal of advocacy in a bunch of different realms, to include special advocacy. There's different coordinators within the agency: Justice Evolved Veterans, LGBTQ veteran coordinator, a women veterans coordinator, aging veteran outreach specialist, and more. Additionally, the Oregon Department of Veterans Affairs has a number of different programs for veterans in their state level programs. There's the Veteran Volunteer Program, Conservatorship and Representative Payee Services. There's the Oregon Veterans Homes located in the Dalles and Lebanon. Oregon Home Loans through the Oregon Department of Veterans Affairs. Rural Veterans Healthcare Transportation Grants, jointly managed by Oregon Department of Veterans Affairs and ODOT. Emergency Financial Assistance Grants, Veteran Service Grants, and more. Additionally, other agencies include the Oregon Health Authority, the Veterans Health Administration, and the Veterans Benefits Administration. The Oregon Health Authority has partnered with Oregon Department of Veterans Affairs to conduct the Oregon Veterans Behavioral Health Services Improvement Study in 2018, and then jointly conducted listening sessions in 2019 throughout the state on veterans' behavioral health issues. Oregon Health Authority has a Veterans Behavioral Health Liaison, Emily Watson. The VHA Office of Rural Health and different community care options also include a number of different resources. So the Office of Rural Health has teleclinical resource hubs, veterans transportation service, telerehabilitation, web-based behavioral health tools, the Veterans Rural Health Resource Centers, and different programs like the Community Clergy Training Program. VHA in general, just like Mary discussed previously, has the Mission Act and Community Care, which allows for utilization of VA contracted private or community providers if a veteran is more than a 30-minute commute to a VA facility. The Mission Act and Community Care also includes urgent care benefits in the local community, My Healthy Vet, telehealth services, Mobile Ops, which is a pilot program in Washington State that allows for mobile orthotic and prosthetic services. There are some rural VA health clinics. There's virtual education and programs. And then also there are health registries. So if a veteran has had exposures through combat or their military service, there are different health registries that they can participate in, receive a health exam from the VA, and then be a part of that registry for tracking and additional information over time. The Veterans Benefits Administration, I'm mentioning, requires application for different benefits, but it is important to know that there are benefits for veterans and their dependents that include monetary compensation for service-connected disabilities, and then potentially monetary awards for non-service connected conditions. So that's really a resource that you're going to want to connect with a veteran service officer for assistance in applying for. And there are a number other of available benefits through the Veterans Benefits Administration. Too many to list, but would absolutely encourage every veteran to connect with a veteran service officer to discuss and explore what benefits they may be entitled to. Nonprofit organizations provide numerous services and programs to veterans and their families throughout the state. I listed a few examples like the Central Oregon Veterans Outreach Program, Pets for Vets, Project Healing Waters, Veterans Yoga Project, Team Red, White, and Blue. There are just so many in the state of Oregon that can connect veterans, provide fellowship, and also provide resources. And they really differ depending on where a veteran is at, where they live. So again, connecting to a veteran service officer is important. National veteran service organizations include those like the VFW, American Legion, Paralyzed Veterans of America, Disabled American Veterans. There are more. All of those include advocacy for national veteran issues, but also have local fellowship. Many have local chapters that rural veterans can participate in. They engage in a variety of different charitable efforts. DAV, for instance, provides free van rides for veterans to medical appointments at the VA. So there's a lot of things that national veteran service organizations are doing and help veterans with. The ADRC, the Aging and Disability Resource Connection, is mentioned. It's a huge information resource for programs and services, not specific to veterans, but for seniors and people with disabilities. And I mention it because, again, even though it's not specific to veterans, if somebody is a senior or has a disability, this service can really be a hub for referral to a number of different programs and services, and it is dependent on where you are in the state. There are trained specialists that answer the calls to that line who have a ton of validated resources that they're able to engage with. They include options counseling, referrals for services, Medicaid and Medicare assistance, assessments, SNAP benefits, connection to Oregon Health Plan, Meals on Wheels, and more. Lastly, the County Veteran Service Officers or tribal veteran representatives are my number one go-to. County Veteran Service Officers are located in every county in the state of Oregon. Tribal veterans representatives are available throughout the state of Oregon as well. They offer free services. They are accredited VA representatives. They're experts in all veteran resources, federally and at the state level, but also specifically know all of the local veteran resources in the county that they're at. They also help with claims representation, advocacy, and connection to all of those other programs that we've mentioned before. Lastly, I just want to mention a few words from the former Oregon Department of Veterans Affairs Director, Cameron Smith. I think it's a good note to end on. Veteran services are not always about providing a service directly, but often more broadly about our leadership, advocacy, and strong partnerships on behalf of veterans. With your help, we will continue to innovate and strengthen our shared efforts. This Veterans Day, please join me in giving thanks to all of those who've served, and are still serving around the world. Let us honor their service on this one day and recommit to partnering together throughout the year to fulfill the sacred trust of caring for all of those who have borne the battle. Thank you so much for your time, and thank you for being a part of this presentation.
Thank you very, very much, Mary and Lacey, for your time and great presentations, and really appreciate your hard work and dedication toward our veterans here in Oregon. With that, we will now go on to our question and answer session.
Good morning, everybody, and happy Veterans Day. Welcome to the live question and answer portion of our session today. I wanted to really quickly let you all know that in the chat box, Mary had asked a question about attendees noticing any specific impacts on the care for rural veterans as a result of COVID-19. So if folks have had seen an impact like that or have some things to share, please do put that in the chat so we're able to follow up on that information. There were also some questions about having a mobile medical unit in Oregon, and there were questions about the where the VA's research offices and rural health offices are, and why they're kind of in a rural or urban area versus a rural, and those are all answered there on the side. So I appreciate people's input there. As well. We got a couple of questions in on our app this morning as well. One from Angela is, as a veteran in rural Oregon, one thing I struggle with is the limitations the VA puts on the care I can seek. How can rural health clinics who might be able to serve veterans help those veterans navigate the VA system and its requirements? I'll let you guys decide who may be able to best answer that question.
Yeah, I guess I can take a stab, Lacey, and then I'll let you chime in. Does that sound okay? Okay. Yeah, I think it depends a lot on the clinic you're seeing. A lot of them do have great history of kind of knowing how to navigate that and will work with you. But the VA is a complicated system, and with changes to it also, that can be difficult for clinics to navigate. I would say the VA itself can be a really good resource. Calling the Office of Community Care or calling their patient advocates and making sure that you're talking with them about the process can help you get access to care in your community and can be a great resource. I'd also say a lot of the community partners that Lacey talked about can be really great. So if you're having trouble, maybe your clinic's struggling connecting yourself or connecting your clinic to veteran service officers or other organizations that know the system really well and can help them navigate through that and understand some of the confusion can be a great way to start that process.
Yeah, I think you really captured it, Mary. I don't have a whole lot more to add. I would mention that I have found that social workers assigned to primary care providers through the VA are another great resource sometimes for access to care. So that's just another thought.
Great, thanks. Another question that had come in on the app was, do you see that very many hospitals, or in particular rural hospitals or rural facilities, having specific veteran advocates in the research and you're being around? I mean, do we see many of those in our facilities?
Yeah, I've definitely seen in some of the larger systems or hospital systems in the billing department, they often have someone who specializes in kind of the VA system and how to navigate that. I'm not as familiar with more of the patient advocate type of role specific to veterans. I don't know if Lacey, you have any more input?
I don't actually. I would love it if there was someone specific in rural hospitals, but I haven't heard of someone specific for veterans outside of billing. So.
All right, excellent. A question, or maybe a statement. Well, actually, one more other question that came in. Are you aware of the VA Navigator pilot coming soon to our area? Are you familiar with that program, or whether it's coming to Oregon in the Northwest?
I'm not familiar with that program yet.
I'm not either.
It was the VA Navigator, is that what it was?
Yeah, VA Navigator pilot.
No, I'm not familiar with that, but I'll definitely look into it because that's interesting.
Great. And for the person who I don't have the name of the person who asked that question, but stay tuned. We will get some answers on that and get that out to folks as well. So
did they, sorry, Bob, did they mean the federal VA, or there is a Navigator program with the Oregon Department of Veterans Affairs? There's navigators that help try to sift through resources. I'm assuming they mean something different though.
Yeah, I'm not clear from that question, okay. So it could be both. But Lacey, if you could give me some information on the role of those Oregon navigators, and Mary, if you can get me any information on what you can find out, we'll get that up when we post this session at the end of our conference. Thank you on that part. One thing that hit me, Mary, when you were talking about the percentage of veterans that do not access the internet at home. At a time when telehealth is becoming such an increasing delivery system for healthcare, that's a rather large number of individuals who aren't accessing. And I'm wondering if you had any follow-up, if that's just because of the lack of actual access to that. Is that a cost thing? And then that leads to a question for Lacey, which is the Oregon Department doing anything with the state broadband office to help facilitate the development of broadband in rural communities?
Yeah, I think that was actually in Lacey's talk maybe, so I might let Lacey tackle this first, and then I'll touch base on what we found in our research too.
Yeah, absolutely. You know, I think it's a combination of things. Some of it is actual geographic barriers to that type of service in certain areas. And I know even especially with the recent wildfires and things like that, that's also impacted that even more negatively. And then I think sometimes it's a cost challenge for people as well, in addition to other services. So I think it's a couple of different things that are happening. I know that the VA has done some things to partner with like Walmart stores or other places where they can have veterans can access the internet or other telehealth services in the store. So they have a dedicated space for those functions in some rural areas. And then, you know, there's some other resources throughout the state in rural areas, libraries and some other options still exist where there's internet so veterans can access that way. And veteran service officers, I always come back to veteran service officers in the counties. They seem to really know what resources exist in their local areas and can connect veterans in that way. So I think we could probably get a veteran connected in some way through some resource virtually anywhere in the state. Now it's a bold statement that I can't necessarily back up with research today, but I feel like through the chain of resources, we could figure something out. As far as the Oregon Department of Veterans Affairs offering a specific connection to internet, I'm not aware of us participating in a direct program that way. We do offer different grants, and so organizations can make proposals for that, if that was something they were interested in expanding on. And I think we're always trying to partner with stakeholders and different community agencies to expand services for veterans, period. So.
Okay, thank you.
Yeah.
Yeah, I think Lacey hit it on the head. I think just it's been interesting to do research during COVID and during this pandemic, and I think we're seeing access to internet and access to telehealth being difficult across the board in rural areas, not just for the veteran population, but also for the general population at clinics. It's just a challenge. We've seen a lot of anecdotes around how clinics or other parts of the community are kind of rallying to try and make it more accessible or to try and make it doable. But I think that's an ongoing challenge in rural areas.
So we have over 80 people on our session this morning, and they're all here because they're related somehow to delivering healthcare to veterans in our rural communities. Both through your roles and the research that you've done, what would you say to the folks that are here today are the top 3 things that they can do to help increase access or facilitate access to care for the veterans in their communities? Kind of a big question. Lacey, do you want to start?
Sure. Gosh, top 3 things. I guess I'll come back to my number 1 is always encouraging veterans to connect with their local veteran service officer in their county and to really seek out any benefits that they may be eligible for. And their veteran service officer is going to know that and help connect them and go through the process to do that. The other 2, I guess I would encourage providers or just resource providers in general, whether it's care or any other service provider that's interacting with veterans, is just for them, even if they've applied for benefits in the past and were denied benefits, doesn't mean that they're not eligible for benefits now, or it doesn't mean that they won't be in the future. So the laws are constantly changing. The VA is evolving. The services are different. And so it's really, in my mind, never one and done. And even if you're getting benefits, continue to check in, every couple of years and see is it time to see if it's, conditions have worsened and you need to file for an increase in benefits. Or with like the Blue Water Navy Act, there are veterans who are now eligible for benefits that weren't before. So always checking in and continuing to do that throughout their life course. And I might have to come back on the 3rd part. I'll let Mary go for the others.
All right, thank you.
Yeah.
Yeah, I'll echo a little bit of what Lacey said, but I think one thing I've thought about a lot in our research is that I think veterans or care providers can often think that care for veterans kind of looks one size fits all thing. And something I've realized is that the VA does evolve, as Lacey said, and things change and access changes. So different ways of getting care, whether it's through the VA or through the community, and there's lots of different pathways. So I would say encouraging folks to, even if they're apprehensive, to explore their options so they're informed about them and know about their options to access is a really big thing and really important. I would say, research and the VA and all of these aspects are, through a federal budget. So I'd say talking with your legislators and making sure that that's a priority and building awareness is also a really nice and important way to rally support for that. guess. And then I'd say, yeah, it kind of in line with my first one, but making a coalition. So talking with resources in your area, knowing beyond just care providers, who are the VSOs, who are the community folks who are involved, and how can you make a bit of a better network and to support your veterans.
Yeah, and you just reminded me too, Mary, I guess my third thing would be for people to be involved. There's so many different opportunities, whether you served or not, to support veterans and their families through service or advocacy in different organizations throughout the state. There's so many veterans coming home, so many veterans that are aging. There's a lot of need. So.
Excellent. Thank you. Well, we are coming to the top of the hour, and I want to thank Mary and Lacey both. This has been a great conversation and presentation. We appreciate all the work that you're doing. I want to thank everybody who's joined today, and happy Veterans Day to all. We do have this presentation will be posted on our website after the conference is over, and we will get some of those questions answered as well that may not have been as clear here in our postings here on the side. And encourage folks to stick around. The next session coming up at 11 is adopting telehealth in rural health clinics. So it's kind of a very relevant transition point from our conversation earlier about veterans being able to access telehealth services in rural. So thanks again, and have a great day, everybody.